Welcome to the other side of Lucy Letby, a podcast that looks at the medical and scientific evidence used to convict a neonatal nurse of multiple accounts of murder and attempted murder. Today we're going to stick with baby A, the first case or the index case or the golden thread, whichever you like. One of the things I find strange about this case, and perhaps it's just because I'm ignorant of the law in the UK, was that the expert witnesses in this trial all gave evidence against Lucy Letby, and they all followed essentially the same script, which is, in effect, the golden thread, that the vivos were stable before they collapsed, that the collapses were unexpected and unexplained, in spite of the fact that there was extensive forensic post-mortem evidence for all but one of three deaths, and that the babies didn't respond to resuscitation like they should have, as if anyone knows how anyone is going to respond to resuscitation. That's simply not the case in medicine. So right from the start, rather bizarrely, in my opinion, all of these babies were said to have died of natural causes, and for most of the babies, there was a very straightforward explanation for why they died. Baby A, in the case of baby A, was unascertained, and as I've said before, that was death by natural causes, unascertained cause of death, so there was multiple reasons probably why baby A died. And the pathologists and reviewers of these deaths never considered murder or deliberate harm in any way contributed to the deaths of any of these babies. So foul play, to use a very colloquial term, wasn't considered by anyone until Darry Evans came along. Darry Evans is a retired paediatrician, a general paediatrician, and he retired about 15 years ago, is my understanding. So he has no current knowledge of medicine. I've been retired now less than 1 year, and I already feel rusty. So I couldn't imagine what it would be like giving evidence in a murder trial 15 years after I retired. And for me, this is a really bizarre situation that Darry Evans, a 15-year retired general paediatrician, was the only one qualified to give evidence, or the one most qualified to give evidence against Lucy Letby. Now, the method by which Evans reached his conclusion is also quite bizarre, particularly in 2023, because he said that he reached his conclusions having it ruled out everything else. And people sometimes call that a diagnosis of exclusion, which doesn't actually make any sense logically. You can't diagnose something because you didn't diagnose something else. So it's bizarre that someone would say because the baby didn't die of A, B, and C, they must have died of D. And it doesn't really seem to matter how ridiculous and the circumstances are, how much they have to stretch the circumstances to make it fit into harm. It simply doesn't fit into harm. For most of the cases, very straightforward. I can understand how some people might get confused by the fake association that they created with the statistics, and that you're starting off from a very biased and prejudiced point of view. You might easily, if you're a lay person, read into circumstances, ill intent, malintent, something like that. Well, it's actually not the case at all. So do I know anything about being a witness at a murder trial? Yes, I do. I was a witness at a murder trial, and it was a particularly gruesome assassination type murder of a young girl, a very young girl who happened to be a patient of mine. And I happened to be on call that night for the area, and I had to go and certify the death, a very brutal, sadistic death. And then, unfortunately, I had to see the perpetrator, who was arrested not long afterwards. And was it a case that there was circumstantial evidence? Well, I suppose there was, because about 30 people seen him at a party, and practically all of them identified him in the court. They did find the murder weapon, which had his DNA on it, and unfortunately the victim's DNA on it as well. So when I was sitting in court getting ready to give evidence, was I going to make up anything prejudicial against this man? Was I going to say anything that was going to in any way impair a fair trial and thus justice for the family to the extent that we can provide justice? No, I wouldn't dream of doing that, and I think most doctors wouldn't. So it remains a mystery to me why the findings of the autopsies were completely ignored in this case, and why there was no counter evidence given for the defence of Lucy Letby. I am mystified why the defence didn't call an expert witness to explain to a jury just how lethal sepsis is, just how lethal pneumonia is, what widespread ischemic damage to the heart means for a baby who's just been born. It would be invariably lethal, and it is not caused by our embolisms or anything else. It is caused by the prematurity and the circumstances, and generally speaking, sepsis, which is what I think was a big factor in all of these cases. One of the strange things that Darry Evans said in an interview, I think it was on Talk TV or something, a media outlet, after the trial, when he said he believed that justice was done in the Letby case, that he gave a criteria for excluding all the other deaths. And we don't know how many deaths there were in the Countess of Chester Hospital. At least I don't know. Somebody knows. But there were more than the 7 that Letby was charged with, and they occurred in the same time frame as the Letby deaths. But Evans said that he had excluded babies from his inquiry who had died of the usual things that babies died from. But the post-mortem findings in the Letby babies were the usual things that babies die from: prematurity, complications of respiratory distress syndrome, pneumonia, etc. So in order to remove all bias from this analysis, I think an easy comparison to make is, what kind of answers would these experts give to external examiners when they were taking an exam? So for instance, if they're asked, does error on an X-ray always mean error embolism? Would they answer, yes, it does? Or would they say, no, of course it doesn't? So the standard that we need to measure these answers by is a simple standard. I'm going to answer the questions the way an examiner would expect me to answer them in order that I might pass a medical examination. Simple. Right, we'll start off with the first expert witness, Professor Owen Arthurs. Professor Owen Arthurs is a consultant paediatric radiologist at Great Ormond Street Hospital. The court hears he has reviewed many of the children in this case and will be asked questions about baby A and baby B. Professor Arthurs is asked about a post-mortem X-ray for baby A. His comments on usual findings in gas are found in the baby boy, including a line of gas in front of the spine. He said such a finding is not found in cases of natural causes of death in babies. Trapped error such as this, Professor Arthurs explains, could be found in cases such as a road traffic accident or infection such as sepsis. Overwhelming infection in the organs of the body, or very occasionally outside of hospital in sudden unexpected death in infants. Prosecution: have you seen this much gas in a baby before? Arthur says only in one other case. So he's only seen error on an X-ray in one other case, and that's of course another Letby case. So he says the finding is not found in cases of natural death due to babies. And then he subsequently goes on to contradict himself, because he says trapped error such as this, Professor Arthurs explains, could be found in cases such as road traffic accident or infection such as sepsis. Oh, that's a natural cause. Overwhelming infection in the organs of the body, well, it doesn't really have to be overwhelming, and overwhelming is a matter of opinion, really. It's not quantified. or very occasionally outside of the hospital in sudden unexpected death in infants, which is a natural cause of death. And then the prosecution goes on, have you seen this much gas in a baby? Well, the amount of gas is really relevant because an X-ray can't measure an amount of gas. Only in one other case, again, here we go. So the prosecution again, what was your final opinion? Professor Arthurs, this was an unusual appearance. Well, I would say a big deal. Medicine's full of unusual things. It's not proof of anything. In the absence of any other explanation, well, here we go, the unexpected, unexplained. This is consistent with our being administered. Consistent with, what does that actually mean? So if you give this bullshit type of answer to an examining board, they'll just fail you on the spot. Consistent with is just layman's term for I can't think of anything else. Consistent with, you can find it with this. Oh, but you can also find it with that. You can find it with this disease, but you can also find it with this other disease. And we've just actually heard the professor name several diseases, particularly infection and sepsis and sudden infant death syndrome, where this is consistent with as well. And you get Benjamin Myers, a lawyer who's now about to cross-examine a radiologist, and he doesn't have any special knowledge to enable them to frame his questioning. So he questions about air in the body and analysis of them. What analysis of them? Analysis of the composition, distribution, an opinion of an X-ray, plain X-ray. It's not really much evidence for anything. Mr. Myers' radiographic evidence of our embolus is rare, isn't it? So there we have the use of the term embolus, which is, as I said, an embolism that's still travelling. Professor Arthurs, yes, on post-mortem imaging, the presence of air may also be the result of medical procedures or placement. Yes, says Dr. Owens. So Dr. Owens said, yes, this air can be the result of procedures or placement. So why are we having this discussion any further then? Can you definitively say, beyond reasonable doubt, or are you sure that Letby put air into these babies? On the basis of this information, you cannot be sure. Mr. Myers asks if the presence of an umbilical venous catheter or long line for some time could lead to air in the system. Dr. Arthurs agrees. Professor Arthurs says that the assumption that an image is needed to prove an air embolism is wrong. And there I would agree with the professor, because we actually do have a technique for just determining that air embolism is present. And it's a criteria for air embolism defined by Perrucci and Gershon. And this is a well-known technique whereby you gather the air, you have to trap it in the body, then gather it, and then send it for gas chromatography. And it is the kind of gold standard, if you like, of diagnosis of air embolus, because this isn't an uncommon problem in medicine, the iatrogenic or doctor-caused air embolism, although there is still no evidence that there's any air embolism present here. So we carry on, and I think something has gone into evidence here that without discussion in this article, it's confusion, but then you get to a bit. Mr. Myers says Professor Arthurs looked at 500 cases at Great Ormond Street Hospital, which after narrowing down the criteria amounted to 38 babies aged under 2 months, and of those 8 had gases in the greater vessels. This obviously refers to a paper published by Professor Arthurs. And Professor Arthurs goes on and says there were no unexplained cases of gases in that location. Cases found included trauma, a road traffic accidents, sudden unexpected death in infants, and congenital heart disease. So we have 2 natural causes there of death. Mr. Myers said that does not include many cases of babies in similar circumstances of death, aged under 4 days old. So it's clear that they're talking about a paper that Professor Owens has published. So let's be clear. Unless the paper Owen Arthurs refers to is about neonates or particular preterm neonates and only involves the use of X-rays, then it's not relevant to this discussion. The modalities and the methodology of acquiring the data that he's now about to discuss should be the same. So Mr. Myers says Professor Arthurs looked at 500 cases at Great Ormond Street Hospital, which after narrowing down the criteria amounted to 38 babies aged under 2 months. Of those, 8 had gases in the greater vessels. Professor Arthurs said there was no unexplained causes of gases in that location. I don't know what location. The causes found included trauma, a road traffic accident, sudden unexpected death in infants, and congenital heart disease. So sudden unexpected death in infants and congenital heart disease are natural causes of death. Mr. Myers said that does not include many cases of babies in similar circumstances of death. And Owen Arthurs says there are many variables in such a study. So what does that mean? There are too many variables to apply anything consistent from the study. That's what it means. Professor Arthurs says error can be distributed in the system during CPR. Well, there we have it. That was the cause of death. Baby Mr. Myers says one possibility of error seen on the image is error administration. Well, that's really stretching it because there's not any possibility looking at this image. You can make a diagnosis of error administration. It simply is insufficient information. He says others can be through resuscitation or postmortem changes, to which Professor Arthurs says yes. So even if Professor Arthurs believes that a portable X-ray is sufficient to diagnose or embolism in a preterm neonate who's just gone through resuscitation, he's just told us that resuscitation is sufficient to cause it. So he goes on to talk about some paper that he published, and he's using this publication as justification, I suppose, in a way for saying what he's saying. So let's see if we can find this publication and see does it meet the same criteria and methodology. In other words, is the paper about portable plain X-rays and the diagnosis of air embolism? Let's have a look and see. So the only paper I can find on J. Arthurs in the European Journal of Radiology, Volume 84, Issue 3, in March of 2015. And it refers to postmortem magnetic resonance imaging, which has a high overall accuracy for abdominal pathology in fetuses, newborn, and children. So this talks about the use of magnetic resonance imaging, which is about 4 light years away from plain X-rays. And even with this, it says overall sensitivity and specificity, 72%, 61 and 81, nowhere near good enough, sorry. So that's kind of the territory we're in. So let's look at another publication. So this is an editorial from Pediatric Radiology in 2015, and it's by Owen J. Arthurs and Rick R. Van Ryn. So it was received in July 2014, accepted in August 2014, and this is what it says. The classic autopsy, the widely recognized as the gold standard in postmortem diagnosis, has shown a steady worldwide decline in the past decade. A large literature review of adults showed that autopsies could reveal a major error rate of 8.4 to 24.4% and a class 1 error rate from 4.1 to 6.7%. So a class 1 error is what's this thing called the Goldman criteria. So class 1 would be where, had the diagnosis found at autopsy been known at the time, it would have altered the outcome. At the other end of the age spectrum, an Irish study in a neonatal intensive care unit showed that unsuspected or unconfirmed clinical conditions were found in 52% of cases, and that in 45 cases out of the 164 that they looked at, information of interest to inheritable conditions were found. So while there's been other studies with similar findings, the decline in autopsy rates is difficult to prevent. parental reluctance to accept an invasive autopsy rather than clinician reluctance to offer one is the most likely cause for this. And it's been attributed to various causes, including religious beliefs, fear of unethical practices. Oh, I wonder why that is. The fact that the next of kin believe the deceased should be allowed to rest in peace, and an emphasis on individual choices made in our society, where the greater good of gaining knowledge can be perceived to be of lesser importance. Oh, wow, that's very sad. Finally, economics plays a certain role, as the conventional autopsy can be both time-consuming and expensive. So it goes on to talk about the value of CT, so that's computerized tomography, just slicing through the body with X-rays, and magnetic resonance imaging. So these are both very detailed, layer by layer analysis of internal organs. X-rays are nothing like these procedures, and they cannot be used in the same breath, and expect people to take it seriously. It's interesting that the letter or the editorial is titled Mortui, vivos, docent in Latin, which means the dead teach the living. If only that were true. Let's look at one more paper. This is entitled Autopsy in a Neonatal Intensive Care Unit, Pathology and Clinical Agreement by Camilla et al. And this was done in the Journal de Pediatrica in Rio de Janeiro. So published online in 2022. So the objective of the paper was to evaluate neonatal autopsy rates at a tertiary hospital in southern Brazil, ascertain the level of agreement between pre-mortem and post-mortem diagnoses. So pretty good. The authors reviewed all neonatal autopsies performed over a 10-year period and described the percentage of neonates who died and underwent autopsy. So during the study period, 382 neonates died at the neonatal intensive care unit, and consent to perform autopsy was obtained from 73 or 19%. And this is the interesting bit. The complete agreement between autopsy findings and the neonatologist's pre-mortem diagnosis was found in only 65% of cases. Additional findings were obtained at autopsy in 25 cases, that's 34%. In 5 cases, the autopsy findings contributed to subsequent genetic counselling, and 7 of the autopsies revealed the diagnosis that would have changed patients' management if established pre-mortem, that's called a class 1 error. The autopsy rate increased by an average of 1.87 each year. Despite the high level of agreement between clinical diagnosis and pathology findings, autopsies provided relevant data regarding the cause of death, providing additional clinical information to neonatologists and allowing genetic counselling for family members. So there we have it. I find a paper that 2022 says an autopsy is still the gold standard of diagnosis post-mortem. So I ask, are we sitting in a courtroom discussing audible X-rays, which can't really tell you much, from an expert on MRIs and CT scans when there's no MRIs or CT scans and evidence, and we're ignoring the post-mortem's findings? It makes no sense to me, and I really hope that someone can point out the logic of all of this. So Professor Owen Arthurs, no doubt a very accomplished man and somebody who continues to do a lot of good work in the world, but I don't know what his purpose was in this trial. He confirmed for us that with the very extreme limitations of the equipment and the information that he could get from X-rays, he couldn't reach a diagnosis either way. It was multiple possibilities, differential diagnosis. But yet he said the most likely cause was, when you rule everything else out, was injected air. But I really can't see how you can say on the one hand that CPR can cause air embolism, but on the other hand, the most likely thing was injected air. I simply can't understand how a person can make that logical leap. That's been quite enlightening for me. This is the level of expertise that we can obviously expect in a murder trial in the UK. There's no attempt here to establish facts, to build fact patterns. We have a lawyer here doing an amateur hour or after dinner discussion with a radiologist about pathology, and that's supposed to be conclusive about a cause of death. But in the meantime, we will ignore the actual findings of the pathologist as a cause of death. We'll not put any of that into evidence. So you tell me how any of this makes any sense, because it certainly doesn't to me. So in the next episode, we'll carry on and we'll look at another expert witness, the daddy of them all, Darry Evans. Bye.